So, today we will focus on a skill that separates an infectious disease specialist from others. So, the day 4 theme is how to interpret culture reports and modify antibiotics. As a senior fellow, I expect that by the end of today, you should be able to answer, is this culture clinically significant? Is it contamination, colonization, or true infection? Is the antibiotic appropriate? Can we de escalate the therapy? Or what should be the duration of treatment? So, in the morning time, the person should go for the pre round preparation, and before this, seeing the patient, he should see, for example, if it is the patient 1 where the blood culture is positive for Coagulase negative staphylococci. So, what questions you should look for? Is every blood culture bacteremia? So, no. A positive culture may represent contamination, colonization, true infection. So, you should know the difference between the contamination and colonization. When should cons be considered significant? Because cons is there in your blood culture, so you should look for whether it is significant or not. So, when multiple blood cultures are positive, if you get more positive in cons in more than 2 bottles, same organism grows repeatedly. Same organism is coming in first bottle, and when if you culture it again, then you get the same thing. Patient has central line, prosthetic wall present, immunocompromised host. Single positive bottles often suggest contamination. Then you should see what should be your first question after seeing a culture report. So, what should come to your mind at the first instance? So, does the patient have sign of infection? Never treat a report, treat the patient. So, if culture is there, no problem, but you should see whether the person is having infection or not. So, this is for your case first, whether it is colonization or whether it is pathogen, whether the person is having symptom or if the person is not having symptom. This you will go for in the morning rounds. So when you after this thing, you should go for the round first, and you will see that 65-year-old diabetic patient is having fever, urine culture E. coli is 10 to the power 5 colony forming unit per ml, and this is sensitive to nitrofurantoin, phosphomycin and amikacin, and it is resistant to ceftriaxone, ciprofloxacin, and current treatment is being given meropenem. So senior asks, can we continue meropenem? Then your answer should be no. If the patient has uncomplicated cystitis and organism is susceptible to oral drugs, then de-escalate. This is the core AMS principle. So what is de-escalation? Switching from broader spectrum to narrower spectrum therapy after microbiological data becomes available. So benefit is reduced resistance, reduced cost, reduced toxicity. Then after that, in 10 to 11 a.m. session, you should see for the culture interpretation session. Blood culture scenario day 1. Blood culture is positive for MSSA. Then is MSSA is in blood ever contamination? So almost never. Treat every MSSA bacteremia seriously. Look for endocarditis, any bone infection, deep abscess, intravascular devices. So, what is the preferred drug for MSSA bacteremia? Answer is anti-staphylococcal beta-lactams like cloxacillin, nafcillin, cefazolin. These are superior to vancomycin for MSSA. Then In the next round, you will see device associated infection. So, patient has central venous catheter as well as fever, and in blood culture, you find Klebsiella pneumoniae. So, for that reason, what should you think? It can be catheter related bloodstream infection. So, what one should investigate? What was the timing of positivity? Catheter culture, then clinical response after the removal. So, these all things will help you. So, when should a catheter be removed? Usually, when infection is due to SORIAS, Candida, gram negative bacilli, tunnel infection, persistent bacteremia. So after that, next what you should see that colonization versus infection. So example, ET aspirate you find Acinetobacter baumannii, but the patient is not having any fever, no leukocytosis, no stable oxygen requirement, then whether you should treat or not? No, not necessarily. It may represent colonization, so you should always correlate with the patient's symptoms. Treating colonization promotes resistance. So, positive culture doesn't mean infection. This is the rule. Now, coming to the antimicrobial stewardship round. So, what are the first 5 Ds? First 5 Ds are diagnosis, drug, right dose, right duration, and then is the de escalation. So, when should antibiotics be reviewed? It should be after 48 to 72 hours. We should review the culture, we should review the clinical response of the drug, biomarkers to check whether the response is there or not, and then go and check for imaging. So, the case is persistent fever despite meropenem, but cultures negative. So, what should an ID fellow think? Not all fever is infection. Culture is negative, but fever is there. You are giving antibiotic. Fever is coming. So, it can be a drug fever. It can be DVT. It can be pulmonary embolism, autoimmune disease, malignancy, or occult abscess. So, what is common mistake? Escalating antibiotics whenever fever persists. Persistent fever does not automatically mean resistant bacteria is there because culture is negative. So, at the end of the day, if you see, most common blood culture contaminant is Coagulase negative staph. Is MSSA in blood significant? Yes. First step culture after culture report is to correlate it clinically. Positive ET culture always means infection? No. What is de-escalation? Switch from broad to narrow therapy. When review antibiotics at 42 to 48 to 72 hours. Positive culture but no symptoms, colonization or contamination. What is the golden rule? Treat the patient, not the culture report. So, after 4, blood culture interpretation, catheter related bloodstream infection should be read and discussed. Difference between contamination, colonization, infection is also very important, and the principles of antimicrobial de escalation. So, if you see, uh, for example, before leaving the hospital, one should always review all the blood culture reports, all the CSF culture, sterile fluid culture, MDR organism report, positive fungal cultures, and then you should see whether it is infection or colonization, what was the source of it, whether appropriate antibiotic is being given or not, or can therapy be narrowed, does source control exist. Exercises blood culture ESBL producing E. coli. Patient afebrile for 48 hours on meropenem. So, in this case, what is the duration? What is the source? Oral step down possible. Need repeat blood cultures. So, in the journal club should be done where you should read one paper related to it. And in the sepsis and early antibiotics, why are antibiotics given within the first hour of septic shock? This is important to answer. What are the risks of indiscriminate blood spectrum therapy? What is diagnostic stewardship? So, antimicrobial stewardship exercise, if you receive the following prescriptions, like prescription 1 is meropenem plus vancomycin and the day is 7, cultures are negative, patient is stable, then one should suddenly think about it. Can therapy be stopped or narrowed? So, it should be done. Prescription 2 is piperacillin and tazobactam is being given. Urine culture is sensitive to nitrofurantoin. So, why to continue with IV therapy? We should start with nitrofurantoin. Okay, patient should be checked for the condition. Then ID board style question is, if the fever 7 days and blood culture is negative, but on echo if you find vegetation present, then you should think whether can infective endocarditis exist with negative blood culture. So yes, it is possible. Culture negative endocarditis is a classic ID problem. So case 2 is ventilated patient is there, and in ET culture they find acinetobacter. So no fever, no leukocytosis, no infiltrate is there. Then question is whether we should treat it or not. But when no fever, no leukocytosis, so it can be colonization. Now next what you should do, this is in the program, take one patient and ask what is the syndrome, what is the likely pathogen for that syndrome, what sample should have been sent, and is source control adequate. Then antibiotic question is why this drug is being given, why this dose is being given, and for what duration. Can it be narrowed? Always take care of narrowing down. Then host question is the patient immunocompromised, any prosthetic material is there, any travel history is there, any animal exposure, any healthcare exposure, because all these things indirectly or indirectly related to different type of organism. Then at the end something should be read, like about blood culture contamination, MSSA, bacteremia, catheter related bloodstream infection, antimicrobial de-escalation, duration of therapy, principles. So what are the good habits of a good ID person? That before sleeping one should ask, what infection did I understand today that I did not understand yesterday? So if your answer to that question daily for 2 years, you will think like an infectious disease consultant. So we will go for the um, next cases in the next day. So that is all about the infectious disease for the 4th day, and we can read about many things what they have given in this unit in detail in the other videos, and if they are going to be helpful you can go through them. This all is from ChatGPT.